Hello?
Hello.
Mario, go ahead, please.
Okay, I'm here, Vidya.
Mario, go ahead, please.
Okay. Good afternoon, good morning, and good evening to everybody joining this webinar on the multipurpose prevention of condoms in the context of sexual reproductive health and HIV linkages. Much has happened in the field of reproductive health in terms of technology and with dealing with the big problem of pregnancy prevention and on prevention and protection from STIs and HIV. We still have to rely on what we have, which is the condom, which is the present role, in which is the most, and the present role of the condoms in the prevention of pregnancy, unplanned pregnancy, and protection from HIV and STIs. So we have this. I welcome you to this webinar, which was organized by the Human Reproduction Program of the World Health Organization, and with support from the Implementing Best Practices Initiative. Can we go to the next slide, please? So I am Mario Festin. I work at the WHO at the Human Reproduction Team at the Department of Reproductive Health and Research. Next slide, please. So this is, so next slide.
Welcome back.
We have organized this panel of 4 global experts to talk about various topics. Next slide, please. So, as I said, latex condoms are the most efficient available technology, but there are many things happening right now in terms of preventive technologies, as vaccines, microbicides, and this webinar seeks to place condoms in its proper preventive context. So we'll have 4 speakers, and we would like to invite the participants to the webinar to look at the screen of this GoToWebinars, and there is a chat box there where you could type your questions. So use the question box on the right-hand side of the screen. And there is note there, if you are interested in additional webinars, your feedback is highly encouraged. Next slide, please. So we have invited 4 renowned experts from practically all corners of the world to talk about this multipurpose prevention role of condoms. The first speaker is Dr. Wiwat Rojana Pithayaporn from the Center of Health Policy and Development from Mahidol University of Thailand. We'll talk about the 100% condom use program in Thailand and its successes and lessons. This will be followed by Ms. Natabeseng Magagula from the WITS Reproductive Health Center in South Africa, who will talk on lessons from implementation of male and female condom policies and programs. After her, we'll have Dr. Mitchell Warren from the AIDS Vaccine Advocacy Coalition, who will talk on the use of condoms in the era of PrEP, implementation, and multipurpose technology development. And our last speaker will be Vidya Deperth from the United Nations Population Fund, UNFPA, and she will talk about what part the condoms play in combination prevention from the post-2015 prevention agenda. What will happen is that we will have the 4 speakers speak one after the other, and at the end of that, we will be, while they're speaking, we're gathering your questions and comments, and we'll have a question and answer session at the end. So we would now like to proceed with our first speaker, Dr. Wiwat Rojana Pithayaporn.
Okay, so I'm take over. Thank you very much. First of all, I would like to thank the organizer for giving me opportunity to give this presentation. What the topic I'm going to present is the 100% condom use program, which is now implementing in around 6-7 countries in the region. And this slide is the title slide, which I am assigned to talk about how it works and what lesson which can be learned for other settings. So next slide, please. Okay. First of all, I would like to mention a little bit about the definition, and I think that this is okay. That it is a program to prevent sexual transmission of HIV, not only HIV but also STI in the general population by ensuring high level of condom use among sex workers. And this one is not among sex workers, sorry, among sex workers and clients. And the objective of this is to use condom, to have 100% condom use, but not 100% condom availability. So I saw many countries, they say that they have 100% condom program, and what I learned from them was the only having condom available. But how can we become successful if people have condom but not use it? So and this program is to ensure that condom use, condoms are used at high level. And the program was developed for the first time in 1989 in Thailand. Next slide, please. This slide shows a photo of of how HIV spread in Thailand, and I think this is probably the same in other countries as well. The slide, what I see on slide is not the complete slide, but anyway, I can explain a little bit. That on the top part of the photo, you can see that initially the HIV transmitted among MSM, among drug user, and also spread through blood transfusion. But starting from 1989 in Thailand, HIV start to be observed in sex workers. And we understand that sex workers contracted from bisexual men, from tourists, and from people who use drugs, and from men who contracted from blood transfusion. Once a female sex worker infected, then she have sex with customer, and very high chance of customer to contract HIV. And once customer go back home, you can see on the lower part, the right lower, that he have sex with his wife and spread disease to wife and then to newborns. And also visiting sex workers, sex establishment again, and spread again to sex workers who spread further to the general population. By this mechanism, HIV start to spread very quickly from 1989 on. Next slide, please. And this slide will explain what the main principle. And in order to understand the main principle, I would like to explain a little bit about sex work in the Asian regions. That mostly sex work happen in establishment, not freelance type, not the walking type, or also freelance type or street type available, but not the major one. The major sex workers are working in establishment which controlled by the owner, controlled by the pimp, and we know that sex worker has no choice except to follow the advice of the pimp or the owners who always want to earn more money. And sex workers also the same. They have no power at all to negotiate condom use. So this principle of this program is to create what we call enabling environment for to empower all sex workers to be able to say no to customers who don't want to use condoms, or what in other words we can use the word monopolizing sex business regarding universal use of condoms. So it means that if condom a customer don't want to use condom, then no way the customer will be able to buy sex service, and those who buy sex service will be the one who willing to use condom. And this is very similar to the because structural intervention similar to seat belts, helmets, and smoke-free initiatives. The only difference is that sex work is illegal, and this is illegal in all countries in the region. In other words, customers will be no longer in control of sex service with regard to the use of condom. And local authorities and the owners are responsible to promote and maintain such enabling environment. This one is to protect sex workers. And when sex workers are protected, then the spreading to customer will be reduced. Next slide, please. So this slide is about the detailed strategy, that is to gain cooperation among government authorities and the owners and sex workers to require condom use in all sexual encounters. And if customer refuse, then no service. Or in other words, no condoms, no sex. And it has to be covering all sex business sectors, which means that customer will have no choice. And then we mentioned about some form of sanction. Sanction means warning, closure, but during the 25 years of implementation, there was almost no closure because the owner and sex worker realized that if all of them stuck together doing the same thing, then they have more power over customers, and the business will be still be the same. Next slide, please. People ask, how can we control condom use? If they promise to use condom but they never use it, it's also possible. However, we have a few mechanisms to ensure condom use, and usually the first one is the most important one. When male STI clients or STI clinic clients come to the clinic to have health check or STI checking, then we interview them on where did they have their last sex, did you use this, they do use condom or not. During the first few years of the program, at that moment, 97.5% of male STI cases have history of contracting disease from sex workers. So it means that if we cover sex workers, 100% sex acts among sex workers and clients, we reduce 97.5% of transmission. And then, and when we protect men, it means we protect wives as well. But we have 5 ways to investigate condom use. So that the detail can be studied in the document that I attach to the organizer. So next slide, please. This slide showed how effective it was, and when this is just one province adjacent to Bangkok. The name of the province is Samut Sakhon. They started the program in 1991 in April. At that moment, 13% of sex workers had STI. I mean, on average, over 10%. But within 2 months, the percentage of STI, which is the indicator of risky sex behavior, the percentage of STI dropped to 0%. And it showed that this is very effective. And because of these findings, the National AIDS Committee chaired by the Prime Minister agreed to implement this program nationwide. So next slide, please. In this slide, it shows the chronological development of this program. It started as a pilot project in one province, 100 kilometers from Bangkok, named Ratchaburi. And then from 1990 to 1991, I have worked with the governors of 13 provinces to implement as a scaling up from the pilot project. And subsequently, in August 1991, the policy of nationwide implementation was formulated by the National AIDS Committee. It was chaired by the Prime Minister. And but it takes time. It took a few months in order to complete all 74 provinces. The last province was Bangkok Metropolitan. So it completed in April 1992. Next slide, please. In this slide, it shows that this is based on independent interview or surveys. In Thailand, they have behavioral survey, or we call sentinel surveillance survey. Initially, every 6 months, and subsequently every year. and still going on right now. We can see that the percentage of condom use start to increase from very low level of 14% in sex workers. We use direct sex workers as the interviewees or the sample group. In Thailand, we divide sex workers into two groups. Direct sex workers mean those who work in the brothel, massage, some massage parlor, some tea house, and the percentage was increasing very, very rapidly from 14% to over 95%. And indirect sex workers, we also have information, and the percentage very similar to the direct sex workers, but a little bit lower. And so what is the benefit of this? Will be seen in the next slide, showing that the next, yes, STI as a good indicator of the risk of sexual activities. We can see that in 1991, when it started from 89 up to 90, when we expand the program to 13, 14 provinces, and then subsequently the prevalence of STI, the incident, dropped down to a very, very low level. It's more than 95% decline of STI. And it's the same for HIV. I'm sorry that I forget to add the slide for HIV, but we found that the decline have been seen in all groups except drug users. All group mean housewife, army recruit, blood donations, blood donors, all decline have been seen. So the next slide, the World Bank.
Your time is almost up.
Okay, the next slide, please. This slide shows that we have prevented over many millions people, many million infections prevented. Please run quickly to the next slide, please. Can you show the next slide? Okay, that there's been so many documents mentioned about the benefit of this. For example, the first one is the Prime Minister of Thailand mentioned that by 2004, 5 million HIV infections have been prevented. Next slide, please. I will end by okay. This one also I get from website. I show that now the 7 countries, in addition to Thailand, have already implemented this program. Next slide, please. I will show this at the last slide. Sorry. Next slide, please. Next slide. Next slide, please. And this is the last slide. I would like to say that this program is useful in countries where sex work is the main cause of HIV transmission, and it can be implemented as a structural intervention to empower sex workers. And implementation requires participation of key stakeholders, including the local government, the owners, and sex workers. And the nationwide coverage is required in order to ensure that customer will not be able to buy sex service anywhere without using condom. And the program is very feasible, as can be seen that it implemented in 8 countries where the social and cultural norms are different. And so I would like to conclude by saying that anywhere in the world, if sex work is a main cause of HIV transmission, the program can be implemented. And the detail can be seen through website. You can just type 100% condom use program, and then many documents will be there. Thank you very much. I would like to turn the floor over to the next speaker. Thank you.
And Tabi Singh, please go ahead.
Okay, thank you. I'm going to present from South Africa. My name is Tabi Singh, as you can see on the board there. I'm the Provincial Head Health System Strengthening Project in SRH Institute that is attached to the Wits University. Shortly, I have been in the, I will start with the first slide. If you can put up the first slide. I'll talk to condom programming in a region in South Africa. And on the background slide, I just want to give a background to show that in South Africa, we are facing a dilemma of a high burden of disease, in particular to HIV and TB, and poor health outcomes. That is despite the fact that the GDP investments are high. And we know that statistically South Africa has a prevalence of about 19.2%, with approximately 7 people living with HIV. And South Africa has adopted the UNA's 1990 policy to control the epidemic by 2020. And this SRH Health System Strengthening Project that I work for is a 5-year project, USAID PEPFAR-funded project, and we are working with the Department of Health to improve the HIV and TB outcomes by supporting implementation of the 99. We are in 2 districts. In Johannesburg, we are in 1 sub-district F. Next slide, please. On this slide, I just want to illustrate that we've got 3 main HIV prevention strategies, the biomedical, behavioral, and structural. But for this presentation, we will focus on condom programming, which is a biomedical prevention strategy. And we will look at only at the sub-district F in Johannesburg. Next slide, please. Now, Beck-Skinsker, Smith, and Mantel, in their study on when they conducted a study on progress and challenges to male and female condom use in South Africa, that was in 2012, they looked at the objectives of condom programming in South Africa, which are on the presentation. The idea was that the objectives were talking to ensuring an uninterrupted supply of good quality condoms to all provinces, and also looking at all the relevant users and the areas, non-traditional outlets where people could access condoms. Some of those are hotels, clubs, puzzle shops, and taxi ranks. And of course, to motivate for provision of condoms in institutions of higher learning, because statistics show that that age group are more liable to contracting HIV. And of course, to ensure that condom supply in high transmission areas like trucking routes, single-sex hostels, and commercial sex work is prevalent. Next slide, please. And we will now, in this slide, look at condom supply in South Africa. In South Africa, the Department of Health is responsible for procuring and distributing condoms in the public sector. But this is complemented by the private sector that is actively marketing condoms at a cost. And we have realized that male and female condoms are distributed widely within communities to promote access. But although male condoms are more popular, there is an increasing demand for female condoms, but we have also observed that the female condoms do not meet the demand. The supply does not meet the demand. And of course, progressing to making the condoms popular, the South African government launched colored-scented condoms to promote accessibility and condom use. Next slide, please. This slide shows the programming in the sub-district F that we are in, which is in the inner city of Johannesburg. And as I mentioned in the previous slide, projection and procurement is done through the province. The province actually bases the projection on the distribution uptake and sexually active male population. And from that, as we move with the process, the provincial source the condoms through using a national supplier. The nation-approved national department approves the supplier, and province source condoms from that supplier and distribute to the primary distribution sites. These primary distribution sites are placed throughout the districts. So district region F has its own district primary site, which distribute to the distribution to the secondary distribution sites. These secondary distribution sites are actually very accessible to the end user, that is the community. Next slide, please. Next slide, please. Okay. Now we will come down to the main condom program supply chain. We talked to the condom supply from national to province to district and to sub-district and secondary distributors. Now we'll talk to the condom program supply chain. So the DOH peer educators support the distribution of condoms from the primary distribution sites. Remember, I said these are in the district, and the secondary distribution sites are supplied with condom cans that are easily accessible to the communities. And these people are provided with dildos that make it easy for condom demonstration. We also, in South Africa, condom distribution from primary distribution sites is the data from is only captured from primary distribution sites, and it is captured in the system that is used for capturing data, which is the District Health Information System. And there is no data that is collected from the secondary distribution sites. And that's Reproductive Health and HIV Institute support the districts through use of the mobiles to reach out to those areas that are unreachable. Next slide, please. Now, this slide just illustrates the progress, because using the secondary distribution, centers that access the condoms from the primary distribution center has shown an increase in the distribution, as you can see from 2012 to 2016. This illustrates that there has been a steep growth in the supply of the condoms in Johannesburg. Next slide, please. Now, this has got its own challenges. As you remember, I will say, I said the province projects for the districts, and there are no formal calculations to accurately project future condom source. And this results in undersupply, and most especially because the districts are not they are not involved in the projection. The projection are done at a province. And the female condom distribution, as I have already mentioned, this is anecdotal because this is what we see in the facilities that and the secondary distribution sites, that the demand is not met. So this is one of the challenges. And usage uptake, there is no data that to determine uptake and usage, because the data is only collected at primary distribution sites, not in the secondary where the real distribution happens. And access to key populations. This is also anecdotal because people say there are barriers to condom access by key populations, especially the adolescents, sex workers, and MSM. This is especially in the health facilities because of stigma and also being afraid of being discriminated on. That is why the secondary sites seem to be the most accessible to these populations. Next slide, please. Now, from distribution, using the secondary distribution sites, we have seen some best practices throughout South Africa, but especially in the sub-district region F. Condom distribution to secondary sites that are accessible to community has shown a great increase in the usage or the distribution rather. And promotion of acceptability through distribution of flavored. The flavored condoms are very appealing to the clients because they say they don't make noise, they are less noisy, and they are acceptable. Now, based on all that, what we have said, we recommend that there is a need to conduct research to determine usage by the general population and key populations, as well as the impact of condoms on HIV prevention. Because we know that in spite of the fact that we are distributing condoms broadly, the HIV incidence is still increasing, especially in the age up to 24 years in South Africa. And we feel that there is a need to also develop a databases at secondary sites so that we can accurately project future needs and procurement at provincial level. So this is the end of my presentation, and I will hand over to the next presenter. Thank you very much for listening to me.
Great, and thank you so very much. My name is Mitchell Warren, and I hope that you can hear me now. And I'm delighted to be part of this webinar and really grateful to the organizers, and particularly to follow both Wiwat and Natabeseng is so exciting for me because both the Thai experience and South African experiences in condom programming have been really pivotal to my own career and understanding not only about male and female condom programming, but about integrated responses to not only HIV, but to sexual and reproductive health programming. So I'm delighted to follow on and stand on their shoulders. What I've been asked to do, and we'll try to do in the next few minutes, is to put condoms in the context of what I'm describing here as a new era. Two things, though, before I go to my slides, and that is really building off of the previous two presentations, that these are probably two obvious statements to make, but I think they're important to make. One is that no single intervention is the answer, and I think we all know that. Male and female condoms are essential components of what needs to be a comprehensive, integrated, and sustained response, and you heard that, I think, in both presentations implicitly. We need lots of options, including condoms. The other thing I wanted to say is we all, I think, spend a lot of time talking about the technologies, whether they are latex condoms, male condoms, or polyurethane or nitrile female condoms, or other technologies that are in development, which I'll describe a bit about. But one of the things that's so important that came out of both presentations so far is that these are never just biomedical interventions. Every condom, every prep, every circumcision, every intervention, in my mind, is a biomedical intervention that incorporates behavioral issues and structural issues. And you saw that so beautifully represented in South Africa, that it's not just about that piece of latex or that piece of nitrile, it's about the systems that deliver them and the behaviors that of both health providers and of users and of their partners. So just to state the obvious, we're talking about not just biomedical interventions, but inevitably that's where we end up. So I'll start there and maybe go to my next slide. So what I wanted to do was just highlight these 7 issues. Now, we talk a lot about multi-purpose protection these days in 2017. A new term, you may hear it as MPTs, but that's multi-purpose technologies. I think of that as dual protection. And these were 7 recommendations that came from a meeting a number of years ago. And I highlight them. I start with these recommendations because they're so important about determining who is at risk of HIV, promoting dual protection among young people and others at risk, about family planning programs, recognizing it's not just women, but also about men and adolescent men as potential clients. Addressing gender, power, sex, pleasure, and negotiation in relation to condom promotion. Again, this is not about a biomedical material. This is about gender and power and sex and pleasure and negotiation, about supporting the other technologies that are needed in the longer term, ensuring coordination, and supporting in the scale-up of programs that are not focused only on products. So I want to go to the next slide, which may look really familiar, because I wanted just to show you where those recommendations came from. Same slide, just the footnote at the bottom. This came from a meeting about condom promotion and dual protection in February 2001, almost 16 years ago. Admittedly, the words I put in italics there are my additions, because I think we have a much better understanding about not only HIV, but the needs for STIs, and certainly not just microbicides, but other technologies. I put this up there for 2 reasons. One, to show you that we were all right back in 2001, and to show you that we are doing a terrible job as a global community, that these are the exact same recommendations that are needed today in January 2017, 16 years later. I do not want to sit in any webinar in 16 years from now, so in 20, whatever that would be, 33, and have to have these same conversations. We have got to do better in addressing these issues. So I'm going to hopefully give you some ideas on how to do that. So next slide. We often talk, in whether we talk about dual protection or multi-purpose protection, about understanding the reproductive health experiences and thinking about the idea that, of course, there's no one method for all people, so different strokes for different folks. This was our paradigm for the first 25 years of the epidemic, from 1981 to 2006. You can see the contraceptive list. We've had a range of methods that people have had, that science has delivered in contraceptives, but in HIV, we had basically barrier methods and behavior change. Admittedly, in 1994, we got the extra barrier method of the female condom approved, or 1993 actually, but since from 81 to 2006, a very slow development cycle. The good news is that if you, as this next slide now shows, you see what has happened from 2016 and beyond. You'll see we have not only behavior change and barrier methods, but we have a question mark with gels and rings, 2 products that have been shown to work in clinical trials, but a lot of questions still about are those products registrable by regulators and available, and that's a body of work to continue. The oral pill in HIV prevention, PrEP, approved originally in 2012 in the United States and now approved by almost a dozen national regulatory authorities, and for the last 18 months recommended by the World Health Organization for all people at substantial risk. Now that doesn't say PrEP is for all people at substantial risk instead of male and female condoms. The recommendation from WHO and from a number of countries now is very clear. It's oral PrEP as an option for all people at substantial risk in addition to male and female condoms, and that's very important. And you'll see too at the bottom then surgical procedures and treatment have been added to the HIV paradigm in both voluntary medical male circumcision and our knowledge that treatment of people who are infected not only is life-saving for them, but is also prevention for people for transmission. Just to say, injectables and implants, those 2 blank spots in HIV prevention, are areas of very extensive research, and in fact, just as the year ended in 2016, a trial of an injectable form of PrEP began in the United States, Thailand, South Africa, and Brazil. So there is a dynamic space, but None of these methods replaces the other. And again, the family planning experience is very clear. When we added a vaginal ring for contraception, when we added an oral contraceptive pill, when we added new implants for contraception, they didn't replace condoms, they were additive. But the one thing that's really important to recognize is that this table very much is about what's in product development. But the important thing is not only do we need to develop more products so that every one of those spaces is ticked off, but we have to make sure that people have those options. And I think many of you on this call will know that if you go into a family planning clinic in many places around the world, women are not given the options across that entire contraceptive list. Many women are only really offered one or maybe even two methods for a contraceptive choice. So what's incumbent on us is not only to develop these new technologies, but to deliver them. Let me go to the next slide. This is a little bit more detailed that I'm not going to dwell on, that just goes into a bit more about what is happening in the research world that is very important as we think about HIV and reproductive health programs. Some of these products are exciting and important and available, like oral PrEP, or need to be made available. Some are still in research and development. None of them, again, replace condoms. And so I just wanted to kind of flag that this is a very dynamic space. Next slide. And this goes in just to a little bit more detail to show you all of these trials that are happening right now as 2017 begins, or that will begin in 2017. It's very important that as we see these trials go, that we have to be very clear in how we discuss this with policymakers, with health providers, and with potential users of any of these products. People get very excited about the next big thing and the shiny new object. The products listed in this table are not available outside of a clinical trial, and many of them won't be available even if they are safe and effective for 5 or 6 or 7 years, which means condom programming must not slow down or be put aside because we think we have these great new ideas. People may eventually have access to an injectable or to a vaccine, but it doesn't mean condoms won't be needed then. And it certainly doesn't mean we don't need condom programming fully funded and robustly done today, because these products are not yet there. So the real message I wanted to give you all is that in many of the countries that you all are in, these trials are happening. People will get very excited about these new technologies, but they do not replace condoms. And our message has got to be very clear as a global community. Next slide. So what are kind of the next steps? I wanted to say that we really need to focus on what I think of as the dual purpose of dual protection. That together we need to ensure that funders and policymakers and program implementers make strategic investments to improve condom use, both male and female condom use, right now for 2 reasons. One, obviously in the short term, they can deliver public health impact. People who have access and are able to use condoms will benefit from them for HIV prevention, for family planning, for STI prevention, and it's good for current public health. But there's a long-term issue here, and you heard from the previous 2 presentations that there are really in-depth programmatic issues we have to address. What do providers know and don't know? How do we get them on our side to promote condoms and other products? You heard in South Africa the challenge of key populations being stigmatized. An oral pill or an injectable doesn't prevent stigma. Those same issues are going to be there when we do get those new technologies. So I'm arguing here that if we improve condom use, not only do we get the short-term impact, but we get the long-term benefit of improving and scaling up the programs with provider training, policymaker engagement that will become a platform for whatever technologies come next, and that's essential. So next slide, please. I really want to end with this 3-part agenda that we all should be committing, and it's very easy to say, I'm a condom promoter, or I'm a microbicide promoter, or I'm a PrEP promoter. We need to all be together in this, and we need to talk about this in 3 ways. We need to deliver the products we have, male and female condoms for dual protection, because they do it all, as well as dual method use of condoms with either hormonal contraceptives and PrEP, because hormonal contraceptives and PrEP don't prevent the other product, the other issue. So hormonal contraceptives don't prevent HIV, and oral PrEP doesn't prevent contraception. So we've got to be thinking smartly about delivering what we have today. We also have to simultaneously demonstrate the need for these additional methods, particularly the vaginal ring that may be the next method out there. And then we still need in the long term to develop the longer term methods, multi-purpose rings, and then co-formulated products. We have to do all three of those things. If we only do the blue, only deliver, we won't end this epidemic. If we only demonstrate and develop future products, we won't end this epidemic. We have got to do all three. So finally, I just want to end with this bottom line from my perspective in this last slide, that no single option will meet the needs of all women and men all the time, in all places, in all relationships. And if you go to the next slide, so it's going to take a portfolio of methods, this combination, to ensure that all people have the options to choose that are appropriate and possible for their circumstance. So we've really got to be building out a comprehensive plan. That's what's essential. So I'm going to stop there, and I am delighted to be able to turn this over to a very dear friend and colleague for a very long time, although we're both very young still, in work, and that is Vidya Depert.
Thank you so much, Mitchell. After the three of you, it's very difficult to come after, huh? But thank you, thank you, thank you. You all are already all condomologists. I was going to try to convince everybody, don't drop the condoms, but actually you did it all. So my presentation is going to be very, very simple. The role of condoms in combination prevention, post 2015 prevention agenda. Next. So we all agreed on that already. Multipurpose device, the only one we have at the moment. And we are so encouraged of the research and development happening almost everywhere, family planning and HIV as well, as Mitchell was just a science. So we are convinced at UNFPA, we call condom a triple protection method because we're really trying to push forward the STI's agenda. Next. So some people were still asking, are condoms still relevant? Why? Next slide. Because of several studies that came out, we have a lot of people pushing UNFPA to say, okay, we have so many new things coming in. When it comes to HIV, people might not need condom as before. And this recent study was published in July 2016. So barely 6 months ago, and it is a great study. We're so happy about it, showing that discordant couples who happen to be using not using condom, and the positive partners is being under treatment and has an undetectable viral load, when they found that after so many sex acts, 58,000 sex acts accomplished by over 1,100 couples, for over 1 year, nobody was infected with HIV. They were not using condom, and that still, nobody had an HIV acquisition. And next slide. So that brought people to say, we might not need condom. And Mitchell was also presenting the PrEP. We also do believe that PrEP is a great medical intervention. And when PrEP is taken, it works very well. CDC is saying it's over 90%. So say WHO, even in the case of people who inject the drug, PrEP is really highly effective. We also have male circumcision. There is partial protection, but actually very excellent because not everybody can be using condoms all of the time. We all know that consistent condom use is not easy. So having a little bit of everything would just help couple, men and women, to be able to have a healthy life. The next one. So when you have all of these prevention methods, the treatment that shows that when you are on treatment, you don't need condoms because you're not getting infected, you have PrEP. When you are high risk, you are high risk of HIV, and you take your medicine consistently. So what's the point of condom? We should just drop the condoms. We receive a lot of requests from that at UNFPA. So my answer is, next slide. Is like, I so agree that we have great intervention, but unfortunately, for millions of people, that is just not an option. not everybody happen to be able to be on treatment. We still have a huge treatment gap. According to WHO, only 41% of people, of adults are under treatment, are eligible for treatment, and much lower level of children, 34%. We mentioned stigma and discrimination when it comes to condom, but that's also the case when it comes to treatment, including PrEP. Michelle mentioned it. Later on, when we have PrEP totally available for a lot of people, we're still going to have issues for people accessing it. We have to decide who's going to pay for PrEP. We still need to know how we can increase accessibility and how people can adapt to the treatment protocol. So a lot of questions. That's why we need to stick to condom. Next slide. At UNFPA, of course, we go beyond HIV. So when it comes to STIs, I put very quickly some numbers when it comes to STI. There are billions of people living with STIs, the curable one and the non-curable ones. And we also, if you do remember, very recently, last year and the year before, we had cases of people having Zika and Ebola that were happened to be transmitted sexually, and the only intervention there were also condoms. We also know that this is not easy because most of these STIs, including Zika and Ebola, people might not fully understand that they are contaminated. So because of lack of symptoms, in the case of STIs, people might also have drug resistance. There might be a lot of very few laboratory facility to diagnose the STIs. So people are just sleeping maybe around, not really knowing that they are infected. In the case of family planning, we have over 200 million women who have an unmet need for family planning. Next slide. I quickly put together the latest research of UNFPA showing that women who happen to be married or on union from over 150 countries have been using any kind of contraceptive methods. But as you could see here, in some places, the pink, no, not pink, but the purple color represent condoms, the male condoms. Condoms is a very effective contraceptive method, even in the context of a union. Next slide. In the case of adolescents, however, oh, okay, it seems like I remove it. In the case of adolescents who are not married, condom is the #1 contraceptive methods, regardless of the region. The purple is the biggest color that we see. So despite the implant, despite everything else, people think beyond family planning. They think about STI, they think about HIV, and condom is that one method that can do it all together. Next slide. UNFPA also invested the last year a lot of money to look into the cost effectiveness of condom. We wanted to know whether it was still worth investing on condoms. And our conclusion, next slide, sorry. Our conclusion is like, just like in Thailand, the experience that was presented to us, if you do invest in condom programming and you make sure that the people who happen to access the commodity also are empowered to use it, to negotiate the use with their male partners, especially in the high-risk group, and they account for 90% of the condom use, we show that over the next 15 years, from 2016 to 2030, we will be able to prevent 17 million HIV cases, 420 million unintended pregnancies, and over 700 million STI cases. So I wanted to be very quick, knowing that everybody else would have already presented all of the other cases, to allow us to have some discussion in all of the 4 presentations and the introductory comments by Mario. So this is really showing that we need a little bit of everything under the skies to be able to give couples, men, women, even adolescents, a way to protect themselves and have a healthy sexual life. Thank you very much.
Thank you, Bidya, and thank you also for the other speakers, Dr. Wiwat, Dr. Natabisang, Mitchell, Dr. Mitchell, and of course for all your excellent presentations. I have received some questions which were entered through the chat box. I will ask one speaker one question at a time on a rotation basis so that we'll give everybody an equal chance. So I'd like to ask the first question to Dr. Wiwat. This is in relation to the targeting sex workers. Since sex work is illegal in Thailand and in other countries, what reward system was used to encourage compliance among local government units, for example, to support these rules for an illegal or unauthorized activity such as commercial sex work? Dr. Wiwat?
Hello, can you hear me? Yes. Since sex work is illegal, then the sex work organizers or operators try to make it hidden. And in the term hidden means that they have something in the front. And sex work is hidden somewhere behind the scene, in the room. So in that case, very difficult for police or for the government to control. However, we can have some other way of sanctioning the business, like checking the ID card of people who go into that entertainment places, etc. So my answer is that it's not an incentive thing, but it is the way to show that they cooperate with the government, so they will not be interfere. Their business will be going on. And since by my presentation, you can see that we have a way to check whether they use or not use condom by looking at the customer who come for STI treatment. And by that way, we can feedback to the owner that we have a way to track down the use of condom. And if they don't cooperate, their business may be interfered to some degree by using the regular rule of Entertainment Act. And that's the way, just to make them feel that if they participate, they will get good response from the government part.
Okay. Thank you very much. I would now like to ask Natabisang mostly about the supply of the condoms in South Africa. And given that data is not collected at secondary sites, do you know how often the condom supplies in the primary stores or the primary areas are replenished or refilled? And also, do the primary sites distribute a consistent number of condoms to support the secondary sites? Because they would be one of the sources for the condoms of the secondary sites.
Thank you very much for that question. Hence, in the recommendations, we have said there is a need to also collect data from the secondary distribution sites, because we have observed and realized that because of the fact that there isn't a way of projecting how much is needed by the secondary distribution sites, the primary distribution site gets whatever the province gives. So projections are really not accurate. So this is something that we have recommended, even with the distribution implementation plans for the 1990. We have recommended that there needs to be proper projection through using the data from the secondary sites, because those are the areas where the community access the condoms. I don't know if that addresses that question.
But are the levels of condom distribution in the primary sites consistent, or do they vary from year to year?
They vary. They vary because that depends on how much the province has procured. So hence, again, between the province and the primary distribution side, we need the districts to be involved in projection at provincial level because they vary. They definitely vary.
Thank you very much. I'd now like to ask a question to Mitchell. Given that there have been many new technologies for HIV prevention that have come on, how can condom use be promoted and maintained with increasing emphasis on microbicides and PrEP, and considering that the politicians might not approve with contraception and would prefer microbicides and PrEP instead?
That's a great question. Thank you for that. And I think the important thing is that in all of our work, as both in advocacy and in program design and implementation, that the most important thing that we can do is to be accurate in the information we're providing. And I think Vidya kind of touched on this. There is sometimes a sense that because PrEP has been approved and recommended by WHO that somehow it's real. The reality is that there are literally a few thousand users in all of Africa and only about a couple 100,000 users around the world, of which almost all of them are in the United States. So while things actually do exist scientifically, they are not available. And we need to be very sure that, first of all, we calibrate people's expectations. The vaginal ring is shown to work in 2 clinical trials, but it's not yet even approved by a regulatory agency. So part of the challenge is to be accurate in the information we're providing. And to be honest about it, the injectable for HIV prevention is very exciting. It is likely 7 to 8 years, even if it is safe and effective. So we need to first be honest about what the timelines are for these. And then I think we really need to do a better job together of communicating this idea of that different people will want different products. Not everyone wants an injection. Not everybody wants to take a pill every day. We know that. Not everybody wants to use condoms, but we need to make sure we are designing our programs and our work so that people are seeing how these products have an interplay. And so part of it is just when we start PrEP programs, for example, in country, that we're not saying this is instead of condoms. So it's how we define and explain both the timelines and what these products are and what they aren't. And the one other thing I would say is that I know that many of us on the call right here fall in love with some frequency with different ideas and different products. The important thing is that none of us should ever fall in love with our products. Having spent a lot of my career on male and female condoms, I think they're amazing, but they're not perfect. PrEP is really amazing. It's not perfect, and none of us should fall in love with the technology because we can sometimes be the biggest problem. So it's being honest and accurate in the message.
Thank you. I'd like to ask
as well.
Excuse me?
I'd like to address this as well.
Yeah, you can do that. Okay, go ahead, Vidya.
I was going to say it's also, the messaging is very important. We have to tell the world that there is over 1 billion STIs, and STIs are not neglected health issues. They create infertility, cervical cancer. We have prostate cancer. Nobody talks about that. And the only methods that we have when it comes to those prevention are condoms. So being parallel and emphasizing the 2.1 million cases of HIV we see every year and neglecting the other billions of STI cases is really unacceptable for public health specialists like we are. The countries that see HIV see even more STIs. So how do we tell the people, use any method for HIV prevention, but if STIs is a risk for you, you have to add condoms to it. Soon we won't have any antibiotics to treat STIs. There are a huge resistance to what we have today. We have also seen the cases of Zika and Ebola that are sexually transmitted and can only be prevented when it comes to sex I'm talking not oral sex, but vaginal and rectal sex can only be transmitted through condoms. What are those messagings for people to be alerted that HIV, yes, STS as well, and as I was presenting before as well, when it comes to the young girls, not to talk about the young boys, their prevention options are condoms is the preferred method. But I don't know whether we're doing a good job to tell the words. Like Mitchell was saying, the new technologies are coming, but the old technology should not be neglected.
I would totally agree with you, that, and actually the new technologies are more or less focused on single outcome interventions, like they're only for HIV but it's the condom which does handle the multiple outcomes prevention. So it's a multi-purpose technology that we are promoting and we should be looking after. Are you aware of any cost effectiveness studies comparing the condom and the PrEP media in terms of prevention?
No, we only did this study that I quickly introduced,
The partner study.
and it will be published this year. But I don't think, Mitchell, I don't think anybody did that yet, because PrEP is new, so I don't think anybody wants to invest into modeling to compare methods. We love to approach the methods as complementary and not really one against the others.
So that is the approach that people should be getting into, a complementary approach.
Yeah.
Let me go back to Dr. Wiwat. I think one of the problems that that Natabiseng mentioned was that they have problems getting data on condom use among certain population groups in South Africa. Would you be able to give some advice on how to measure and how to estimate actual condom use as based on your experience in Thailand that can be done for other countries?
I think it's quite difficult because this is a sensitive question. When you ask people whether you have sex or you use condom, sometimes it's a very very unlikely that you can get the real message. Anyway, the way we did or we are doing in the last 10, 20 years is the anonymous type of reply when we perform survey. We have a box like in the past we use a questionnaire survey. We ask them and then they put in the box. We won't know who replied that. I mean the answer. We cannot trace back to the person to answer, and that's the way that we are quite ensure that it's better than just face-to-face interview. Because in that case, if face-to-face, it's very difficult to get the real answer. And also,
it's like an anonymous survey, a blinded or anonymous survey.
Yeah. So that my answer is to do it anonymously. Okay. Yep.
Okay.
And also I would like to add that in the 100% condom program, we also we can trace back by asking customer of the sex business, in particular this one linked with sex services, with sex workers, that we look at establishment base. When we ask male patient of STI clinic coming and ask when they have sex with sex worker in that particular establishment, and we count the number of people who came from or who have experience exposed or having sex in that establishment. And then we look at how many of them answer that they did not use, for example. So then we can trace back to that location, but we cannot trace to the individual sex workers. We know overall the establishment as a unit of calculation. But for young people, we use school-based anonymous questionnaire survey. Thank you.
Okay. Yes, I was really getting worried about how getting data from individual or independent sex workers because it's really much easier to get information from establishments. Let me go to Netabiseng.
Yes.
You mentioned that there would be some specialized training. Would there be specialized training on addressing stigma for the key populations, such as adolescents, men having sex with men, and the LGBTI community in South Africa?
Yes, thank you very much for that question. We have seen our government coming on board in addressing stigma, especially the government is really taking it up to see that there is some training and there is some campaigning against stigma. It's something that is being embarked on, but we are not there yet. You still find some pockets of stigma and discrimination, but honestly, even our police are being given training on how to work with these people without harassing them. So there is a strategy to look at reducing stigma.
Mitchell, would you like to also address the issue of targeting the LGBTI youth in terms of messaging for condom use and prevention? Because this is also a problem that they face in terms of using condoms or using the other things as well.
Absolutely. Well, I guess there are two really important things to say, and one is kind of a structural issue, that we're talking about a population that in many countries or in communities around the world are marginalized and stigmatized and in some cases criminalized. So reaching them with any service or product or message is already complicated. And so it has to be very culturally sensitive to that reality, and that's not unique to condom messaging. That's about how do you engage communities that are in greatest need and hardest to reach, and that is in many ways what makes a population a so-called key population. So I think part of it, though, given how many programs there are right now looking at key populations, I think one of the things we need to do better is to be sure we're not all going in separately. It's hard enough to reach these communities and engage them. I think our experience, whether it was with condoms or with PrEP or with human rights work, is to really work with known and trusted partners in that community and then integrate these messages, really layering them to best effect. I think going in with any one of these messages separately actually is less efficient and less effective. So I think it's really about figuring out the best way to access with the most comprehensive information, and again, being very context specific, so working with trusted local partners.
Thank you. Bidya, you mentioned that there is a problem about measuring condom use among young people, especially because many countries don't allow open distribution of condoms to them. How do you propose that we address this problem?
You're so funny, Mario. I put the question for all the panelists to answer me. Because
but you can do it first, then we'll ask the rest.
I want to hear from the three others, because we were told that we have to measure, to do everything we can to reduce the, at least HIV incidence among young people. And one of condom is one of the intervention. But at the same time, when we help the countries develop their national strategies on condoms, they want to give the condom as the age of 18 plus. And you look at sex, how do you call that? Sex, the first time young people have sex, and then it happens to be before the age of 15. So I'm asking Mitchell and the two other panelists, how do you do that? Can you help UNFPA, because we're lost?
Yes, maybe we could start with Dr. Wiwat with the extensive condom use program in Thailand. How did you approach adolescents? Do they have open access to young people?
But people try to distribute condom in schools, and I can say that forget about it.
Yeah, forget about that. That's not working.
Just forget about it. But then we tell young people to use condoms, and we inform them about the source of condom, and it can be everywhere except in school. We asked sectors to have a what we call the condom dispenser or something like what can I say? That you put a coin and very cheap, let's say 5 baht, and put into this condom dispenser at the toilet or some areas, some shopping areas close to the toilet room, and then it can be available at cheap price. At the same time, in the easy, what you call most convenient stores, they have condoms available. The problem is sometimes the price a little bit more expensive. However, it's okay that people feel that for safety, they would like to pay. So safety means both unwanted pregnancy, STI, and HIV. So in this case, we monitor condom use every year among young people. It's very sad that the percentage is still 60–70% only, and we hope to push more and more by having more sources of condom close to the young people when they have sex among themselves.
Can I ask you a question on that, Doctor? What about, you mentioned the CAP program in many countries. Have you worked with countries that are not very comfortable with the ideas of condoms for young people? Because that's the places where we work the most, the African context, where condom is not really so easy, and countries sometimes don't even have the budget line for condoms, so they get it from the donors, and they tend to mainly put it in the health centers and social marketing organizations. There is no such things like condom dispensers. It might happen, but 1 month after, nobody is replenishing them, and nobody allows condom distribution in school, and sex among young people is not really well seen. So outside Thailand, do you happen to know experience where people are not comfortable with condoms?
As I showed in my slide, 7 other countries also implementing this 100% condom program. But they are not targeting young people. They are targeting the most risky population, that is sex workers and clients, because the percentage of prevalence among sex workers much higher than young people in terms of HIV. However, we are now trying to work more on young people because the sex worker sector already now fully achieved, and still even every year that we did survey, the condom use among sex workers still at very high level, but among young people this is also a problem. However, we try to inform the policy makers that investment in condom is a very cost beneficial investment. For example, there was once that the Thai government, Ministry of Health, did not want to buy condoms for pre-distribution anymore. That they said that it should be the role of users to use it like toothpaste, like soap. However, when we calculate that 50 million baht of condom used for free distribution saves 73 million baht of drugs for STI alone, not to mention about the benefit from HIV drugs that government avoid already from the 100% condom program. It means that it's a very cheap investment, but the achievement from such investment is so huge that the government would be more happy to continue supporting condom, and that's still be the case.
Let us hear from Netapiseng and how the experience is in South Africa.
Yes, thanks. This is very interesting because in South Africa, the condom distribution to the colleges, it's widely done, and all colleges have got these distribution con cans. But in the schools, it's still not happening, and actually, understandably, because in schools, children are still under 16. The age for condom use is supposed to be 16, and the schools will not allow condoms to be distributed there. But in the colleges, in almost all colleges, the condom distribution is done. But the use of that is questionable because teenage pregnancy and HIV prevalence is very high in that age group, the college age group up to 24. But it's used broadly, and the government also supports use of condoms for the youth.
The youth start college at 16 or 17 years old, right? In South Africa. When do they start college? At what age? 16, 17?
The colleges.
Yeah?
The age,
Hello?
When do they go to the university? At what age?
Usually, the earliest would be 16, 17, 18. So it's almost at that age that they are at colleges.
Okay.
But the younger ones, those that go earlier, wouldn't be allowed to use condoms, but since they are put in condos, they can easily get access to them.
Any quick comment from Mitchell before we wrap up?
Well, just, I know we're at the top of the hour almost, but just to say that this issue of adolescence is so essential, and it's not at all, it's not only about condoms, of course. It is, you know, really become the focus rightly because of the epidemic, certainly with HIV, but also for STIs and unintended pregnancies. And we have got to figure out how to reach adolescents and engage them on their terms and on their turf. Their turf, although they hopefully are in schools to some degree, we know the structural barriers to condom delivery there, and that it's as bad or worse with PrEP. But there are many other ways to reach them and many other places to reach them. So we just do need to get smarter. And again, I just want to end by thanking you all, but also I may be a broken record, but it's really about a comprehensive, integrated, and sustained response. And that means we have got to integrate all of these pieces. We have got to be comprehensive in our technologies, in our behavioral work, and in our structural work. And we have to really be looking at how to sustain this, both in financial terms, but also you know, programmatically and politically. So the task is huge, and young people are the focus, and we need to be really working across activities and not in our silos. So I hope 2017 is a year to really break the silos and work in a different way.
Okay. So one quick word from WeWat, very quickly, because we have to wrap up. Oh.
Sorry, most country policymakers, they feel unhappy and to promote condom because they cannot control it, and they feel that it's too difficult for them. So that's why they are fighting for some other alternative methods. So I would like to request the WHO to continue to push or to advise government that the condom is still important, and the WHO needs to support or whatever program to promote condom use in all countries as before. Thank you.
Thank you very much, and we would like to refer to this slide, which is our website, but we also would like to inform the participants to the webinar that this will be posted in the HRP video library, and there will be on YouTube. I would like to thank our four speakers, Dr. Wiwat, Natabi Seng, Mitchell, and Bidya, and our organizers, Ados May of IBP and Stephen Nurse Finley of WHO for this. I think the message is that the condoms remain to be the standard for multiple prevention use, because it has for use for multiple prevention of many things, pregnancy, HIV, and STIs. But there are other interventions available now, but we have to either work with condoms. We don't leave condoms behind because they're still there as the hallmark or the flagship method for prevention. We also have to look at the multiple targets, the adolescents, the high-risk groups like the commercial sex workers, and those in very hard-to-reach areas. So on behalf of the organizers, I'd like to thank again the presenters, the participants, those who attended this webinar, and we look forward to your participation in future webinars. Thank you. Good afternoon, good evening, and good morning for wherever you are. Thank you and have a good day.